Ripe Fruit is a nonprofit education initiative dedicated to identifying and strengthening innate skills as they appear along the spectrum of ways we think and learn. Our mission is to infuse mainstream learning with enhanced curriculum, customized lesson plans, and demonstrated creative systems. We aim to foster comprehensive learning, enthusiasm, and confidence for all students. The DEAN Talks serves as a conduit, think tank, and intensive to discuss how to identify and support unique learning styles. All systems are go. The DEAN Talks starts now. What a powerful introduction. I always like that video. Welcome to the labels edition of the DEAN Talks. We're going to tackle a sprinkling of the diagnosis process, creative therapies, how labels can be helpful, and whether or not a diagnosis is just for the privileged. How can we find the juxtaposition of representation and labeling to rediscover acceptance? The views expressed do not necessarily reflect the views of the hosts or sponsors or Ripe Fruit Foundation. This information is not intended to replace therapeutic or medical advice. This session is being recorded. We have a quick video to take a look at, and we will then begin our DEAN Talk interaction.
A mental health label in order to get support. That's a bit sad, I think.
If you're saying that psychiatry has a tyranny over society, that's going to stop certain people from looking for support.
Are you satisfied with the diagnosis that you have? Where are you, brother?
This way. No, ish. I basically think that labels are for things, not people.
And how do you feel about your diagnosis?
I think it's but the good thing is that it's enabled me to get some support that I wouldn't otherwise be able to get. I had to wait 3 years and it was hell waiting for it.
I've had anxiety for many years, probably same with bulimia. I knew I had it. I just needed someone to say it to my face. It was just a relief to have a reason for it.
It was nice to realise that it wasn't just me being weird, being different, to know that there are groups and there are other people that do suffer with it, which really does make it easier to deal with.
A diagnosis it's completely up to you what you do with it. It's just a label.
It was a bit of a relief to get a diagnosis because it took over 10 years, actually 12 years to get the diagnosis.
How many diagnoses do you have now?
I don't know.
I hate my diagnosis. The main one that I have is borderline personality disorder, and I hate it with a passion. People start seeing you differently. Professionals, family, friends, professionals see you as attention-seeking and manipulative, and they see it as not a genuine illness.
If I were to get rid of my diagnosis tomorrow, I wouldn't be happy about it, because when I was diagnosed with bipolar, it was like people suddenly realised that I wasn't just doing things for attention's sake, like self-harm or trying to take my own life. It was because I have a brain disorder.
When I was hearing voices basically, and they were going to give me a diagnosis of paranoid schizophrenia, my mum, she came in and she said, do you think you could rethink that, because it could be potentially really stigmatising. And as a result of that, they changed it. It's much more about subjective views and opinions.
Okay, that was very powerful on many levels, and I got something out of that, which, and I'll just be quick about this, but when you kind of look at the history of diagnosis, there was a time when lobotomies were the way to go. It's like take a stick and put it in your brain and turn the blender on. And then we went to electroshock therapy, which is put a squeegee on your or sponge on top of your head and put electricity through it and then scramble your brain that way. And now we are in an age where I think there is more sensitivity towards conditions that may not be as visible as other conditions, as far as physically manifesting. You can see a broken bone, but can you see what may be broken inside? And we have tools now that can help us with that. So since we're kind of leaning into the medical side now, I want to introduce our feature spotlight guest today, and that is Mark Bates. And Mark will be unpacking privacy and protections for diagnosis and medical information. Mark Bates is a registered vascular technologist and director of non-invasive vascular imaging for George Washington Medical Faculty Associates, with over 30 years experience in medical care since before HIPAA regulations were established. Ebony Kinney and Mark Bates, welcome to the Dean Talks and the interview portion of our session. Mark, welcome.
Thank you so much, Steve. Thank you for having me, Ebony, and inviting me to the Dean's Talks. I think it's a very important conversation to have had, and I commend you all for taking the first step in bringing this to reality.
Thanks for joining, Mark. And so we're going to kind of interview style ask a few questions. So what is HIPAA compliance and how does it overlap with the conversation about neurodiversity?
Well, HIPAA compliance was designed to, it had a twofold method or reason in the beginning, was to help to cover any type of patients leaving jobs, meaning that when a person left from one job to the next job, they didn't sometimes have medical coverage. So that was one of the main reasons to start HIPAA, was to guarantee all Americans that if you're leaving one job to the next, that you will have coverage until that job kicks in. The second reason was to establish guidelines for medical information and how it's distributed throughout the medical community. HIPAA is a very interesting and very complex type law. And so everything that we're discussing today will be somewhat of a surface level, just to give some insight on what HIPAA actually is and what it actually can do.
Oh, sorry, I'm on mute, thanks. And so when you think about HIPAA covering diagnoses, what kind of protections exist for a person with a diagnosis?
Some of the protections that exist, outside of that for diagnosis is the, once again, when you bring HIPAA back into full focus, there's some very stiff monetary type of levies that are placed on what we call covered entities. And covered entities are entities that handle any type of medical information, and that would be in the form of hospitals, doctors' offices, clinics, any type of venue where there's an exchange of information. And so that because of that, because of the stiff monetary and some of the sanctions that they put upon you with HIPAA, they make it very difficult for you to go outside of that realm without imposing punitive damages for that particular piece.
Okay, great. So, then when teachers, there's basically a penalty for violating it. And so when teachers share information to each other, or maybe share to a school nurse, administrator, to maybe really protect the student or provide resources for a student, how can they protect themselves against maybe a HIPAA violation or some sort of penalty?
And that's a very good question. And we're kind of speaking in some of the abstracts right now, because once again, as I alluded to earlier, HIPAA is a very complex legislation that governs how we transfer or how we distribute information, healthcare information. in my experiences, I've seen it go both ways. I think that in this particular piece, and I think we're speaking more so about more of a student aspect of how this is handled, which is somewhat outside of the true medical way that we look at things as far as for adults are concerned. So it becomes it becomes more so of just using best practices, using more common sense on how we're dealing with this type of information. As far as adults, as far as the term healthcare standard now, there is a release that you would have to sign in order to even have a conversation about any type of medical illness or any type of medical diagnosis. And when that is in place, it makes it very difficult for you to step outside of that. And when I say stiff levies, I mean that because there is, you can be fined up to $50,000 for one infringement. It depends on how bad the situation or how much information was actually leaked out. It's very important to understand that these particular situations, they have gray areas. And so those gray areas have to be looked at dispassionately, but using more common sense. For instance, if you're having a conversation about your health to someone else, then if that information leaks out to someone else and someone uses that information, then you have no legal aspect to protect yourself as far as that's concerned, because you chose to give that information out. You chose to distribute that information in a way where everyone could hear it or someone could hear it and take that information and walk away with it. So you have to be very careful with that. The majority of these types of information, as far as digital, verbal, or written, has a very specific type guidelines that you must follow in order to safeguard that information. But if you and I were just having a conversation about what type of illnesses that we encounter or what type of problems that we're going through in our medical lives, then that's a conversation with just you and myself. But if we're having it in a public venue, then that information can still get out and get leaked out. And you're, in many cases, if the person that you're speaking about is not specifically you, then you are liable for any other information that someone may overhear that you're speaking about with someone else.
Thank you. That's a great, I think, starting point for us to kind of think about how we conduct ourselves, and definitely covers how someone should care for information about their own diagnosis or others. Thanks for this time. Really appreciate you and your time. And I'll turn it back over to Steve.
Okay, thanks again, both Ebony and Mark. That was enlightening. And I was unaware of that kind of case-by-case situation that's involved with HIPAA requirements. So let's continue, and let's now begin introducing our panel. And the panel will self-introduce, if that's a word, maybe I just made that up, I'm not sure, but we're going to proceed. And our first panel member is Tanasia Hazelton.
Good morning, good morning. I'm delighted to be here. I first want to say happy Pride Month and happy belated Juneteenth. I bring a lot of different identities into this room that makes this a very fitting place professionally for me to be, but also a place that's very fitting personally. So I'm a Black, queer, neurodivergent woman, and I was diagnosed with ADHD and bipolar in December. So this is a very fresh topic. Professionally, I am a master social worker who specializes in helping organizations to have edifying experiences for all people and outcomes. I'm also the founding solution specialist of Infinitely Impactful Solutions, through which I do what I just now said, and also strategic impact planning and implementation. So I'm glad to be here, and pretty much I've always had DEI running through my veins and had to be an advocate for it personally and professionally. So thank you.
Okay, thank you very much. Our next panelist is Nomita Advani.
Unmute Nomita.
Sorry about that. Hi, I'm very happy to be here too. I'm professionally a licensed art therapist, been practicing art therapy for the last 14 years. And prior to that, I was an educator in a private school for kids with learning differences for about 15 years, and a visual arts educator, and also visual arts department head for 10 of those years. And having been on the education side and now as a therapist, I really, really appreciate what these talks are doing for everyone, and, you know, really helping on, because trying to really sort of help our education system improve in helping those who need it. I think this is an amazing thing, and I'm so excited to be a part of it and just participate in any way I can. Thank you.
All right. Thank you, Nomita. Angela Fuentes.
Hello, yep, I am also super excited to be here. I am an occupational therapist, and I'm willing to bet that most people in this meeting don't have a full sense of what that means when we say we're occupational therapists. But I'm excited to kind of, I guess, sort of like self-define what my role is as an occupational therapist, especially as a DEI advocate. I see DEI work so integral into what I do as an occupational therapist, and I feel like it's almost like a synonym. So I'm excited to talk more about kind of my perspective on things as an OT. So my practice has been recently aiming to promote participation and justice for culturally and linguistically diverse clients, which also includes forced migrants and refugees and neurodiverse clients. And yeah.
Okay, thank you so much for joining us. And that is our panel. And of course, my name is Stephen King, and I will be your host. Let's get started. What is, for the undiagnosed, let's talk about the dangers. For example, using Google to research versus a doctor, and taking medication that's prescribed versus self-medicating. This is a question for the panel. So panel members, feel free to jump in about the undiagnosed and self-diagnosis versus medical, self-medication versus prescribed medication.
So thank you, Stephen. This is and to my fellow panelists, this is a very multi-layered question. And one of the things that I do want to say is that self-diagnosis happens before anything else happens. When you recognize within yourself, and self-awareness and self-diagnosis has to continue even after when you first get your diagnosis, that's like first step of a billion. And so there is a place for understanding and self-awareness in terms of what's going on with you. But there's also a danger with it, because with self-diagnosis comes self-medication. And whether you consciously medicate or even subconsciously medicate, if different habits that you may be leaning on, like food, like sex, like different relationships, like different hobbies that may be high risk potentially. When you do medicate that way, it can cause further challenges and or further damage. And when you self-medicate with either substances, controlled or uncontrolled, there can be negative interactions between those different drugs. And working with somebody like a psychiatrist or a psychiatric nurse practitioner is a way to limit and or completely eliminate any interactions between potential modes of medication.
All right, thank you. And let's continue. Angela.
Yeah, kind of just on this topic, it kind of just makes me think that diagnosis is just a very kind of Western concept. In our Western cultures, we tend to just focus a lot on ourselves. And so diagnosis, kind of just means, this process of understanding yourself and how others perceive, how you present. And when I work with clients of non-Western cultures, I have clients from regions in Africa, like Asian countries, and I have a lot of clients currently from Afghanistan. And we typically sort of see that they are much more inclined to let others define them, and they don't really have that same process of defining themselves. And I think that we have to kind of just learn to make space for the fact that diagnosis can mean so many things to different people. And even that word itself doesn't literally translate into other cultures. And it's kind of just a matter of asking people point blank, can you tell me about yourself? And you just sort of learn that way. So yeah, I think it's a kind of a Western concept, and it's something that I think we should learn as healthcare providers, especially as, for me as an occupational therapist, it's been really important for me to learn that I don't actually need to have the diagnosis on my patient's chart in order to provide effective care. Because yeah, again, it's a very sterile scientific concept, and it doesn't always translate into what we see in real life. But yeah, we're gonna, I'm sure, go into much more nuance about that pretty soon. But yeah.
Okay. Very interesting. What you brought up was kind of the relationship between Eastern and Western medicine. So let's stop there for 1 second. The Eastern medicine, or kind of the holistic approach, certainly is very appropriate for, in some cases, some of your chronic conditions, like diabetes, for example, high blood pressure. Some of these things can be managed in a very holistic and Eastern way, have been for thousands of years. Western medicine also has its place, and I'll tell you where that is. That's going to be a gunshot, for example, where a surgeon needs to come in and repair soft tissue, reestablish blood flow, like a trauma surgeon, and that would be an example of Western medicine. So for the best patient care, or for the best care, take the word patient out, it's a combination. It's using that kind of holistic approach for the long term, and then kind of dipping into the Western approach as needed. I'm going to stop there, and we're going to continue this question with Namita.
Thank you. Yeah, and then just speaking about the Google rabbit hole, I think we have to all be so mindful of that. I know I do it. I'm sure we all do that. And understanding that diagnosis kind of is an overarching thing, and we have to also think about the individual and case by case basis. So, we have to make sure that when we look at, diagnoses on Google, it tends to be more of the overarching, where it's just trying to cover every possible scenario, and that can just, end up being more confusing, rather than someone really understanding their own specific situation, even within a diagnosis. So just wanted to sort of touch on that aspect.
Okay, very good, excellent feedback. So we will continue. What's the upside of diagnosis? And for that, we'll continue with Namita.
Yeah, so I think, just watching that video clip, we were able to see some people express the relief from getting a diagnosis. There were some people who were talking about the fact that they had spent 10 or 12 years, with these symptoms that they live with, and feeling different from other people, and wondering what that meant and how that can impact your self-esteem. So, the upside of diagnosis and the place that it has is to finally be able to somehow name and find some self-awareness in terms of what exactly has been going on, and that it's not unique to you, that there is something that other people may also be experiencing. So I think, that sort of impacting your self-worth in some ways, being able to start to love yourself again and recognize that this is not necessarily a negative thing, and that it's just something you have to now, you have that first step, you have your diagnosis, and you can start to figure out what you do with that. And, because when you get help, whether it's therapy or meds or whatever it is, unfortunately or fortunately, we require a diagnosis to be able to receive that. And so that also then, pushes you forward into getting that help and taking those next steps and starting to improve your life. So that's one of the upsides, I think. Yeah.
All right, Tanisha?
Yes, getting a diagnosis was important to me, and I also professionally recommend it, because it's not about prioritizing a doctor's opinions of you or professional understanding of you over your own, but it's about aligning in your understanding of what's going on with you. And I think of it as having a medical or mental health support system. Like, you have your personal trainer, you have your mom to call after a hard day, etc. You might also have your psychiatrist or your therapist or your evaluator come alongside you in this journey. as a person who's been a clinician, a person who's a social worker, I thought that I would be exempt from all of the stigmas that come with mental health challenges, but I'm not. And for that, I have my support system of mental health clinicians who can say, hey, you're getting into that stigma loop again. Medication is not, doesn't mean that you're weak, et cetera. So having those objective professional outside opinions to come alongside you in the diagnosis is something that can help you in the times when, or help someone in the times when they want to quit this journey altogether. There's a big stigma that people want to have mental illnesses or want to cry wolf, so-called, but it's a hard journey to show up for yourself in this way. And so having a diagnosis provides that professional objective support system that can help you through the life of your diagnosis, because no mental health illnesses don't just disappear that way. They are to be coped with and treated.
Okay.
Also, there are unfortunately some supports in the workplace and education that are not given unless you have a piece of paper, and that's unfortunate, but having a diagnosis can provide much needed supports in the workplace and in education.
So that leans into the consistency of the diagnosis process in schools. And Angela.
Yeah, that's a great transition. Yeah. So yeah, I work in school-based practice currently. I have been for the past few years. And I think I'd mentioned I work with a highly diverse group of students. I have actually one school, it's a charter school that has about 98% enrollment of English language learner students. Most of them are Somali American or Somali refugee migrants. And I have been very much firsthand experience with the issue of consistency of diagnosis. In fact, when I started working in this school, there was like an active state audit where they're essentially kind of threatening to shut the school down because they found this like huge overdetermination of students with disabilities. And actually I live in the state of Ohio, and Ohio is now has like this statewide effort to kind of curtail its overdiagnosis of students, especially students of color in our communities that are have less access to equitable resources. And from what I've seen from the perspective of an occupational therapist, you know, this plays out on like the individual professional to student interactions on a day-to-day basis where you know, sometimes we'll have a therapist take a student and give them a standardized test that is, you know, not in their first language, and there's not an interpreter available to complete the test. And especially when we work with students of, you know, non-Western cultures, they might not have exposure to written language. They might come from a very oral culture where, you know, they're much more accustomed to speaking instead of writing. And then suddenly you're giving them this test where they have to kind of complete tiny little mazes and all these, you know, like fine motor kind of activities. And it's just not fair. It's, you know, we're setting them up for failure essentially. So I've kind of, I've learned how on these like small interactions, it creates this large scale issue of overdetermination and just a lack of consistency. And then, you know, the result is like suddenly all the services get pulled because the pendulum swings and we can't, you know, reasonably support all of these students with needs. And that's why it is so important to just be much more holistic in our approaches and to give a variety of supports and to know that, you know, maybe we're going to provide individualized services for 6 months instead of an entire school year. And then next school year, we'll revisit the idea of, you know, making a determined diagnosis, because in schools, especially when we make the diagnosis of having a learning disability, it stays with the student for pretty much the rest of their school career. It's really hard to kind of have that taken off their record. And it can follow them sometimes even into employment and the rest of their life. And it's a pretty heavy process. And all along the way of making this determination, we have this huge team of social work, counselors, teachers, principals, and even the students' parents. And everyone has to be equally informed about kind of the determination that's being made. And sometimes not everyone agrees, and sometimes the parents have less awareness of their rights, especially again, if there's a language barrier or an education barrier with the family. And all of these kind of nuances, again, kind of create this lack of consistency and just unfairness. And yeah, I can talk more about this, but yeah, I wonder if anyone has any questions about that, because it's kind of specific to a lot of school legislation, but probably just stop there.
Yeah, thank you, Angela. Ebony, if you're speaking, you have to unmute. And I'm going to take a look at one of the questions that came up in the chat. So this question comes from Amy. And Amy, this is really, very relevant when it comes to diagnosis versus identification and self-identification. So there's something to be said there. It's almost, you can become aware and seek support yourself, or perhaps sometimes third parties may get involved and make you aware. And what that leans into is, law enforcement, for example, is a person manifesting in the street with maybe Tourette's, and the police respond. And the police officer is not trained in anything that has anything to do with neurodiversity or Tourette's. All the police officer sees is someone being very vocal and says, hey, you're creating a public disturbance, I'm gonna take you to jail. So there's a lot of opportunity for, for all of us to really do a deeper dive into the core of what these manifestations are. And that is why these conversations that we have here in the Dean Talks are so important. We have Ebony Kinney off mute.
Yes, and I just wanted to chime in something Angela said, just to tease it out a little bit more. There's some data that suggests that maybe they aren't disproportionately diagnosing BIPOC students or students from marginalized communities. But that's not the experience I'm getting from frontline teachers and social workers. And I think that's an interesting point. If you just did a Google search, you would kind of get the wrong impression about that. Is that your opinion, or the panel's opinion as well?
I'm sorry, just to clarify, you said that there's evidence that shows that the overdeterminations are valid or support?
Well, there was one study. That said that they, yeah.
Yeah, I'm sorry to cut you off, but yeah, I can kind of speak a little bit more to that. And yes, that is very much a valid point, and it's important to kind of tease out some of these nuances. In Ohio again here, we have a lot of students who've had exposure to lead paint growing up, or still have current exposure to lead paint in their houses. And this, again, this creates that mercury exposure, which can vastly and intensely affect learning abilities. And so yeah, it's not always wrong and invalid. Especially when you do the process really well, and you do have consistency in the diagnosis and you do have everyone informed, it still can kind of create this large disproportionate need for services. So yeah, there's definitely a lot. It's not just kind of racist intent, it's also just a variance in need. It looks like there's a question here.
No, that's great. And that's kind of what I was, sometimes there is this thought that maybe there was an intent or a racist intent, but just to know for sure, is there a disproportionate amount of people being diagnosed or misdiagnosed, as neurodiverse? That would help frame a conversation that we can grow from. And I don't seem to be getting a clear, even understanding if people are being disproportionately diagnosed.
Yeah, it definitely is not super clear. And then another kind of issue too is that we see, especially in kind of more of the behavior sciences, is just determinations based on bias of how people present, and voice volume, body language, the way that gets interpreted as a disability truly, when it's really just a variance in culture and behavior. And it just comes from a need for lots of training, lots of teacher training, and lots of teacher support. But yeah, clearly we are sadly far from that, I think, especially now post-pandemic, with teachers being understaffed and undertrained and underpaid. So yeah, there's just so many, but yeah, when we get into the school-based practice, it definitely has a lot of challenges, and it's not straightforward.
Okay, I wanted to give Nomita the opportunity to unpack a little bit more about the explanation and validation of diagnosis. What is the upside?
Yeah, so I think, there's so much that we need to understand, and we don't see how bright a student is unless, they have a diagnosis and they get that IEP, for example. because they're dealing with a system that is not set up for them and for the way they learn and for the way they can really thrive and be successful just like everyone else, but because they need to have a different approach in how they learn. And unless they get that individualized plan that gives them and sets it up for them, because unfortunately the school in of itself is set up in this very old-fashioned, way where the system is already in place. And so that's why we've had this need to create IEPs and things where students then can access learning to actually be able to show their potential and reach their potential and know their potential, because they're being placed in these environments that don't allow for that. So I think that's why the diagnosis, because we need the diagnosis to get the IEP, for example, so that we can have children access our school system in the way that they need it, where the IEP kind of forces that. Like you have to have these accommodations where a student gets, whether it's extended time or whether it's, access preferential seating or whatever, that student needs, or sort of the headphones to be able to quiet the sensory overload and things like that. So I think since we are so dependent on the diagnosis to receive that and to accommodate and change our school environment for the students that can then, reach and show their potential, because otherwise it doesn't show in the kind of school systems that we have, the generic school systems that we have in place now.
Okay, thank you very much. Let's continue and let's talk about emotion regulation and extremes, and let's talk about responding to our environment, whether you're a neurodiverse person or not, and what's going on in the world with school shootings, inner city murder rates, and even in response to the recent Roe versus Wade overturn. What is our role of support for each other? Angela.
Yeah, I think our role of support is definitely just, I think even before we're talking about what we do for each other, we have to talk about what we do for ourselves. I can just kind of circle back to when we first joined into this meeting to get ready. I just was kind of still struggling to get myself together. I was still eating breakfast and it was, 10:30 and cleaning up after my cat. And last night I was at a protest for the overturn of Roe versus Wade. It was a whole day of mourning for me. It still kind of feels really overwhelming. I have to kind of, after this, I'm going to figure out what I'm going to do for the rest of the day and what people I want to be around and don't want to be around. And it's just this idea of, okay, this is kind of emergency mode. I'm feeling like my body is just not safe. And I feel that, my emotions are just kind of out of control. So it's, what do I need right now? I'm on summer break for school, but if I were working, maybe I would have to call off or, make sure I told my assistant that they can call off too if they need to. And so I think it really kind of goes back to, some of like what we look at in our DEI research of, white supremacy culture here in our country. We are very urgent and very perfectionistic. And, the mentality is like, suck it up, keep going. You cannot miss work. You cannot even sit still for a second. You have things you need to be doing. And I thought it was just so great. We kind of got the benchmark of starting at 10:30, but be ready by 11. So I came in around, 10:45 and I was ready by 11. And so that's how we practiced non-urgency. It's this idea of not adhering to rigid rules. And so that's important for non-neurodiverse people. That's also super important for our neurodiverse people who just need us to practice non-urgency and flexibility and open-mindedness. And it kind of reminds me, when we're talking about diagnosis, this idea of it's just an emotional experience, when like Tanisha was saying about how it's, you learn for yourself and you have to have that self-awareness, and it's such a self-affirming experience. I think that just validating our own emotions is just so important. And I think that it's kind of how it feels to get a diagnosis. It's someone else validating your feelings. And that's just truly about emotional function. And it's just very important. It governs kind of how we behave and what our socialization looks like. You can tell I'm probably just kind of being a little spacey. I feel like I'm not presenting as my best self right now.
You're presenting very well.
Thank you so much. But for me to be able to kind of come in and say, hey guys, I'm having a hard time right now. I'm going to do my best. I'm also going to be eating breakfast over here. So that's a lot of what we do as occupational therapists who work with our neurodiverse clients is, just really practicing the skills of self-awareness and self-regulation. And it's not always a linear way. Sometimes OTs kind of practice self-regulation at a very developmental sequence, but people can kind of be all over the board and being really high in certain areas of self-regulation, really low in other ones. But ultimately, we just work on affirming our self-experience and then being able to communicate that to other people, whether that's, I need a break, or I need help, or I need to leave the room, or I need my headphones. It starts with like that self-understanding, and then just creating environments and having access to environments that reaffirm your self-experience is so important for emotional distress. And yeah, I think I really appreciate this space for being able to say we are all in emotional distress, or we are at risk of experiencing emotional distress because of the state of our country and the state of the events going on. And again, I think relating that to diagnosis, we have to name the problem. We have to, say what's going on, because just denying reality is going to create more emotional tension. And yeah, I think I'll probably stop there, but
okay,
definitely a great point.
Yeah, Tanasia, can you piggyback off that a little bit more?
Yes, absolutely. I'm always ready to talk about white supremacy and capitalism and its effects, especially in any DEI space, because that's the overarching umbrella. It's why we have such trouble with diversity, because it's the opposite. Diversity and equity and inclusion is the complete opposite of what our country was built on, white supremacy and capitalism. And so I posted in the chat 15 characteristics of white supremacy culture, also sometimes called the culture of whiteness or whiteness culture, by Tema Okun and Kenneth Jones from the Dismantling Racism Workbook in 2001. And Angela pointed out so many different characteristics, from perfectionism to sense of urgency to quality over quantity, worship of the written word, individualism. These are so the ways that we help ourselves and help each other are by identifying the ways that white supremacy and also capitalism eat away at our processes, and are most of the time at the foundational level of our processes, and begin undoing that and begin pulling a reverse. Really, it's past time. And ways that we can support each other more on an individual level and support ourselves on an individual level are by minding our sensory inputs. Whatever you're listening, I haven't watched anything. I don't plan to listen to anything about Roe v. Wade or police brutality this week. I'm cutting it off. It's a wrap. And I am here. This is my contribution. I won't be listening to anything, but I'm here at the Dean Talks and contributing in this way. Also, in terms of and thank you so much, Ebony, for providing this space for us to contribute in this way. And thank you, Angela, as well, for your protest. And the last thing that I'll say in terms of sensory inputs is get you a fuzzy blanket. Be mindful of the clothes that you're wearing, things that are touching your skin all day, every day. Make sure that you're wearing your favorite outfits. When you look good, you feel good. Get back to the basics of self-care and just doing what feels good. Your body has wisdom. Your body is a source of knowledge. And so when it feels good to your body, a lot of the times, not with everything, but a lot of times it's good for your soul.
All right, excellent. So we are, I have this agenda, and I just, I'm trying my best to stay on the agenda, but it's just these conversations are so engaging that I find myself going off script all the time. But since you guys don't know what the script is anyway, so I guess it doesn't matter. Now, okay, so I wanted to jump, here's the interesting thing. I wanted to kind of jump to, can we cover some creative therapies? And that's really where I was going next. When Tanasia just provided a creative therapy, which, let me just unpack it. Be happy about yourself. Wear your favorite stuff. Be mindful of what is touching your skin and what is around you. And understand that can influence how you feel. So with that said, we're going to go ahead and continue and bring Nomita back into the conversation as we talk about, Nomita, what are some creative therapies?
So I think, art therapy, music therapy, movement therapy, those are sort of the ones that are most used and, most talked about. And they've been newer therapies, but in the last, I would say 20 years have been gaining more traction. And people are starting to understand that, talk therapy really focuses only on your cognitive part of your brain. And we need the whole brain to be used in order to understand everything that's going on, and particularly the sensory areas of the brain. So therapies like art therapy or movement therapy or music therapy really are able to access those sensory areas because they're nonverbal, and they're giving you that opportunity for tactile and visual and auditory, listening. And so they're really accessing, they bypass your verbal thinking brain and go directly back into that nonverbal emotional area, sensory area of your brain. So it's really important to be able to include that. And I think, a lot of mental health providers, a lot of mental health hospitals now have actual programs that include the creative therapies because they've started to understand that. There's been more research to show that that's been necessary. And particularly when there's trauma, things like that, it's not stored in your verbal brain. So we can't access it without some kind of a creative therapy. And that includes, sort of like what Tanisha is saying, learning how to understand how to quiet your senses. So it's the senses that get heightened and triggered that cause us to behave in, maybe ways that are not helpful to us. And so we have to be able to go to that area of ourselves, that area of our brain, and use tools and modalities. So the modalities like these creative therapies or actual, tools that are sensory that can ground us and sort of help us to, because until you are grounded, your thinking brain gets very fuzzy. And, when we are anxious, we lose our thoughts. We forget what we want to say because it takes your cognitive brain offline when we are, heightened sensorily, or when we're anxious, or when we get triggered. So it is really important to be able to immediately give yourself access to these sensory ways to learn how to reground yourself so you can come back to your cognitive brain, and all of your brain is being integrated and able to work together to be able to sort of bring you back, make you available, and make you be able to sort of center yourself and do what you need and get what you need.
Okay. I'm going to continue because we're kind of in a cadence here. So I would like Angela to lean into some creative therapies.
Oh gosh, I didn't realize I was on mute the whole time. I'm sorry if I was like making noises to show myself. I'm sorry, I just blanked. Stephen, can you give me that one more time?
Sure.
Yeah, we were just going through creative therapies, and we had Tanisha talk about creative therapies, and we had Nomita, and now I wanted to give you some space to just talk about creative therapies.
Yeah. I feel like the term is a little bit new for me. I kind of had to do a Google search of it just to kind of see where I fit into that space as an occupational therapist, but definitely something that as an OT, I involve highly. We kind of say that we balance science and creativity with all of the work that we do. And that kind of looks like creating a structured plan for the client or the student or the child, but also just knowing that it could change at any point in time, and that it kind of follows especially when we're in pediatrics, it follows the child's lead. And yeah, usually we call it more like play-based therapy, which, truly is seeing the fact that play is a human occupation. It's something that's existed throughout our entire human experience, and it's essential for life. It's essential for self-regulation. So like Namita is saying, this idea of quieting and calming the body. It's also necessary for stimulation, like, waking up our nervous system and experiencing the world and taking in information into our body. And it's also really important for social engagement. It's not always necessary, especially with some of our neurodivergent clients. It can feel overwhelming and too intense to engage play socially. So maybe we're just going to do solo play for, however long it takes for us to kind of gradually build up to social play, if that's even something that we're capable or willing to do. Truly play is just this idea of, how do we engage creatively and how do we engage our total body senses. And it really is exciting for these types of therapies. There's a lot more research coming out that is just showing the validity of what we do as creative therapists. And I think it gets a really bad rep. I think, again, going back to this idea of white supremacy culture, and there's just kind of this sense that we don't have time for play, or that's not essential to life, or that's, you know, superfluous and extra, and you have to work to earn your play. And that's something as a therapist I have to really make sure that I undo. And you know, sometimes what we'll do is we'll play before we even start our kind of schoolwork or our hard work, or we play while we do our schoolwork. Maybe we can, you know, play basketball while we're learning the alphabet. Because again, it's just very essential that we're engaging our body optimally. You're either going to be, you know, too overstimulated to learn, understimulated, and we want to get you somewhere in the middle so that you can engage in your schoolwork and your academic work and be ready to learn, which is what I always say to my students. You know, and I'll ask them too, I'll say, you know, what do you need to start to learn, or what does your body need to learn right now? And again, it's this idea of, like, as a therapist, we always want our students to build their own awareness of what their body needs. We don't, as therapists, want to say, oh, you need to go grab your fidget swing, or, you know, go grab this and, you know, it'll make you feel better. That's kind of going into like that prescriptive model, or like that like much more kind of like Western model of healthcare where you're doing to a client. But whenever we're engaging in a creative modality, we want to do it with our client, and we want to kind of even ask them, like, what does that feel like? What does that taste like? What does, you know, how does that make your body feel right now? And again, just build this self-awareness of how their body is interacting in the environment. Because over time, they'll have the skill to know, oh, I'm feeling really, you know, it's really hard for me to focus right now. My body needs this, and they don't need me there to tell them what they need to do. And that creates self-empowerment. And truly just, you know, liberation from environments that can just be really oppressive.
Okay. You are listening to the Dean Talks. I'm your host, Stephen King. We have a great panel here, and we have an engaging audience as well. And this topic can go on and on and on and on and on. However, we are going to now turn this over to Ebony Kinney for our big hits and our takeaways from this session, the Dean Talks. Ebony?
Okay, thanks. And everyone, we're winding down in just a few minutes. Thank you. This is obviously going to be one of those conversations we continue. The big hits for me was just knowing that that there's still work to be done around standardized testing. That there's, you know, not that they've changed the standardized test and it's doing everything it needs to do in order to gauge intelligence, that there is still work there. That self-care is important. It's not good enough to just absorb it all and power through. We need to be working in things that are going to support us. That you're not yourself when you're triggered. And there's a way to get access to your sensory brain, as opposed to going through this sort of through your cognitive brain, which requires you to verbalize and think through, well, what could it potentially be? You can go in through the music. Thank you for that wonderful point. So creative therapies may not be a universal term. It might be seen as whole brain therapy, but you need to find out what it is you need. And then if you need to ask for it, kind of talk through it. So the languaging is maybe still in development. And I've learned a whole lot of new terms, you know, pharmacy culture, so well said. It's like, now that you've heard the term, it's like, yes, I know what this is now. So lots of great takeaways from this. If you had other takeaways, please put them in the chat.
Okay.
Steve?
Thank you. So now we're going to take a look at how to contact our panelists. Nomita, contact information, please.
I have an email address that I will put in the chat, and I can be reached that way with any questions or comments. Thank you.
All right. And Angela, how can we reach out to you?
I definitely use Instagram pretty frequently, and I'm also on LinkedIn, and I'm happy to connect with anyone who's interested in occupational therapy through LinkedIn. And yeah, I think that's the best way to reach me.
Okay. Tanasia?
Yes, I can be reached on LinkedIn at Tanasia H, and also Hazel. I'll put my email in the chat as well.
Okay. And as a default, you can always reach out to Ripe Fruit and we will be able to provide contact information for any of our panelists. So with that said, our next session next month in July, the homework, parenting, potential, and purpose will be the next Dean Talk. Make sure you visit ripefruit.org. That's ripefruit.org for more information. I want to thank everyone for participating. This has been a stimulating conversation. Thank you for joining us on this month's Dean Talks. My name is Stephen King, and a special thank you to you, Mark. I certainly appreciate you joining and bringing that information forward about HIPAA.
Pleasure's mine. Thank you so much.
All right. So once again, we will see you at the next Dean Talks. It's ripefruit.org for more information. Take care.
Thank you, everyone. Have a great one.
Thank you. Self-care.